Just do it half an hour.
Hello, everyone. My name is Mike. Thank you so much for joining today. Just a couple more minutes. We're making sure that everybody has a chance to log in. Please take a look on the bottom. You should have a chat function where you can say any questions, ask any questions, and I will do my best to answer those as we go. And we will also have Q&A at the end of the presentation as well. So we'll get started in just a couple minutes. Thank you so much.
So I just locked them.
All right, thank you. All right, good afternoon. Thank you so much for being here. Let me take off the. Okay, cool. All right, since I'm alone here in the room, I'll go ahead and. Yeah. So, good afternoon. Thank you for joining us again. I'm Dr. Nieto. For the patients that know me or providers that know me, and for the new patients that we have on this webinar, welcome. Thank you for being here and taking the time of your day to be with us. Today, my goal is to educate the patients and providers on the simple things that I see every day in order to try to attempt limb salvage and also prevent amputations. What I do, or what I specialize the most in is basically diabetes, diabetic foot wounds, and this is what I'm going to be talking today about, conditions that I treat in the clinic often. So with that said, there's different types of ulcers. It depends on the location, if it's the leg or the foot. It depends what kind of condition causes these wounds. For the most part, we see two major issues, that the patients have. Usually a circulation problem or a nerve problem. With diabetes, those are the two main components that get affected in the legs and the feet. The first I would like to discuss is the venous wound. Venous means veins, and then again the wound is caused by the veins not being able to pump the blood, and that causes the wounds to get red and swollen on the left side, as you can see. Once the patient has been referred and properly treated by a specialist, like a vascular specialist, who deals with improving the circulation on the vein side, the patient's wound starts to shrink and the redness and swelling get better over time. Obviously, with that requires also wound care. Obviously, that's why we're here to help you. At the diabetic wound center, we see these wounds as well, and you don't have to have diabetes to to have these conditions. And we still can see you in the clinic even if you don't have diabetes. So over time, these wounds do hurt, they are painful, and we do obviously the best we can to help the patients heal as fast as we can. We're actually now open 7 days a week from 8 a.m. to 6 p.m. So you're welcome, even to walk into the clinic, and obviously even if you're a new patient and you want to just call us, and if you have a question. The next wound is the arterial wound. So this is completely different. It's not because of your veins, but because of your arteries, the things that carry your blood from your heart and your lungs down to your toes. There's a blockage, then you don't get oxygen, then that causes these wounds. So again, it's very essential that we send these wounds to a circulation doctor to get this fixed, a vascular doctor. And again, we work together, as a team to make this work under the same roof. We try to get this seen as soon as possible. The faster we heal you, the better the chances of preventing an amputation. The next wound is the diabetic foot wound. Diabetic because obviously the nerve damage obviously caused by prolonged diabetes or uncontrolled diabetes. If your blood sugars get better, your sensation comes back, but not all the time. If you have circulation problems as well, that can cause neuropathic symptoms, numbness, tingling, burning sensation on the feet. So my goal is, one, to treat your wound, obviously, and heal you as soon as possible. Number two is actually to make sure that these conditions get treated so we don't so that we don't have a complication again in the future. As a foot doctor or as a wound, also as a wound care specialist, my goal is not, again, to heal you and prevent if I can. The next is actually not even, again, you don't have to have diabetes to have wounds on your feet. You can have poor circulation or pressure. Some patients are in a wheelchair or in bed most of the time, and then they tend to put extra pressure on the heel area or the foot, and that can cause pressure wounds. So with that say, I always tell my patients, look, you can do a 30, and my providers as well, the 30-second foot check. We show our providers, like the ones I go and talk to, how we can check for pulses on the sides of your feet. If the feet are warm, that's a good sign of good circulation. But still, we need to get that checked. With diabetes, that it is affected, at some point in your life. If you don't have diabetes but you're a smoker, that can cause obviously these changes on your blood vessels, and that can cause poor circulation as well. As far as the sensation, obviously, we check, with the special tools in the clinic. But if you feel numbness and tingling on your feet, that's basically something to be worried about, because that can cause you to step on a nail or step on a toothpick or whatever the case may be, and that can cause you a wound and an infection and amputation. So always check, in between the toes. If you see a redness and swelling of your feet, even if you don't have a wound, you can have like a beginning of a complication, like on this case, the patient in between the toes, he developed this wound that if he had not seen in between toes, it could have become a deeper wound and caused him an amputation of that toe. So at the diabetic wound center, we created two slums. Basically the hot foot, which means infection, blisters, ulcers, redness. If it's hot, swollen, and you have something on your skin, that's in my opinion, that's an emergency. It needs to be seen as soon as possible. Why? Because it can cause you your infection to get worse, and also your unfortunately an amputation of the foot. The other term we use is the cold foot. The cold foot is basically obviously the opposite. The foot looks purple, dark, and it doesn't feel warm. And that's obviously signs of poor circulation, and it can lead to gangrene and amputations. So at the Diabetic Foot and Wound Care Center, we say time is tissue. The faster you act, the better. If you take too long, unfortunately, the complication that can happen is obviously losing your leg. So I always share my stories about my experiences here in town. I'm going to go through a couple of examples of patients I met in the ER or in the clinic. So this is one of the patients I met in the ER. He had an ingrown toenail. I never met the patient before. He's never been sent to our clinic. He was trying to cut his own ingrown toenail, and he said to me the first time, Dr. Nieto, obviously first time I meet the patient, he said, I tried cutting my nail off, and I kept digging there inside the toe, and I kept digging white stuff out, and he didn't know, but he was actually cutting his bone out. And then until I did an X-ray, and I was able to see this, his X-rays, I can see that he was cutting, into the bone, and he infected the bone. Thankfully, his case was not severe. And I was able to open, obviously do a procedure to clean the infection out and shave the bone down and wash it. And he was able to keep the toe. But this is, again, something that can be prevented. If he was sent to our clinic and have, studies and, proper management, it could have been prevented. And that's why I say time is tissue. If he had, again, this patient had this infection for months, like he didn't seek the adequate care. The next patient is something similar. Basically, it looks like a blister, right? On the left foot, it looks discolored, it looks purple. And unfortunately, when you open this, I see this every day. So basically, I know this is not something superficial. It looks like an abscess. So again, time is tissue. Again, if you act quick, we can try to save it. We can open this and remove and evacuate the infection. If the longer you wait, the longer we compromise the tissues, and the higher the chances of an amputation. On the next slide, this is a patient who basically was, he had a wound on the tip of the toe. He's had it for months. He's seen multiple other doctors. He came to our clinic for a second opinion because he was never healing. And we did an x-ray and showed that he had bone infection on the right side, as you can see the x-ray. So with bone infection, you can treat the bone infection with IV antibiotics, and wound care, like dressing changes. But sometimes the patient has had that condition for a while, and basically he requires one step ahead, and that's what the surgical management. And we try what's not surgery. Obviously, that's the standard of care says that we try everything but surgery to begin with. But if the patient doesn't have improvement, then we do obviously give the options to the patients. And if they want to proceed, we do what we can to clean the bone. That's what we did. And the patient was able to keep his toe. Again, we've had patients from other practices or clinics, they've had these wounds for years, and we provide them with different options, technologies in our clinic, including grafts. These are patients that I've had in the past, and basically, we basically were able to like clean these wounds in surgery and put these grafts, and over time they healed. So another topic I would like to talk about is Charcot. So there's deformities on the feet. Obviously, people sometimes have bunions, hammer toes, those toes that go like this, and that can cause the pressure in the wound. In this case, this is a patient with what we call Charcot arthropathy. Charcot arthropathy is basically an arthritis that happens with different causes, but diabetes is one of them. And it can cause the collapsing of your arch. As you can see on the x-ray, you see this bump right here is a big lump of bone. That can cause extra pressure, and then the wound becomes chronic and usually doesn't heal. We can obviously, again, we try what we can without surgery, and we try obviously to mobilize the patient, put them on a cast or a big wood. But if that doesn't help, again, I've had patients that they've had this treatment for years, but they never were given the option of a surgical debridement where you can shape this bone down, or you can do the next procedure where, it's actually a reconstructive procedure in that patient, and then you can basically help the patient with the pressure in the area of the wound to help them heal. Sometimes they don't have to have these wounds, they can just have their foot collapse and missing, sometimes they miss bones, and they can have multiple fractures and their foot is not functional. And then we can do procedures to help them try to, make the foot work. But those procedures is what we call a limb salvage procedure. It's basically the last attempt we do before an amputation, unfortunately. And again, in our hands, we try to do what we can, and that's what we try to offer the patients, all the procedures we can to save their feet, including the hyperbaric oxygen chamber. So if a patient has had bone infection for many years, they've had multiple IV antibiotics and debridements and surgeries, but this is a technology that has not been that there's basically a lot of places in town don't have. So we have it here at the Wound Care Center. We have this hyperbaric oxygen chamber, and basically provides hyperoxygenation of the tissues throughout the whole body. And when it gets to the feet, basically it provides healing of the tissues, and it's an option that we provide here at the Wound Care Center. Obviously, there's criteria to this, and we have to meet the criteria of the insurance companies and make sure that we have done what's available before this treatment. Okay. So this is an example of one of our patients that, on the right side, basically the patient had a wound, a chronic wound, and then on the left, on my screen here, and on the other side, basically we have the wound that has healed over time with the oxygen chamber. But I want to make sure that you guys understand something. If the patient has, again, a circulation problem, we can do these wound debridements. You can have multiple weeks or months or years of wound care, but the wounds are never going to heal. And that's why I want to emphasize that we have to work as a team with other doctors, primary doctors, vascular specialists, endocrinologists, kidney doctors. We all need to work as a team. And that's why I want to give you a couple examples of patients that had, this gangrene, and basically they ended up having an amputation by somebody else, and they didn't have the proper circulation, and then they end up having, obviously non-healing and gangrene of the foot. So, again, these are patients that, need to have proper and adequate treatment, and basically once they have improved circulation and improved blood sugars, they tend to heal better. Okay. This is again another patient. Again they have this wound for many years, and then all of a sudden they get the treatment necessary to heal, and they heal over time. So with that said, obviously, to finalize my presentations, I'm here to share all the information I can to try to avoid amputations. Kern County is actually one of the counties with the highest amputations rate in California. And the reason I actually came to Kern County is actually to make that difference. I want to be able to prevent amputations. So, I'm here to do the best I can, Monday through Sunday, 8 a.m. to 6 p.m. every day of the week. We're here open for you guys. If you guys have an emergency, come over and we'll be able to see you. And obviously, with the COVID, we're trying to avoid taking patients to the hospital, but obviously if there's a situation that needs to be addressed, we'll take you to the hospital to get this better. Any questions? Let me see here. I have a couple questions here.
I have a question for you, doctor.
Yeah.
So we have a question from Mrs. Soto. What are signs that would lead you to the conclusion that an amputation is needed?
That's
so really,
yeah,
we prevent amputation. So the question is, what are the symptoms that you look for to come to us so that you avoid an amputation?
Yeah, that's a good question. And actually the most important question, why we're here to make a difference. So basically, what leads to amputation is the basic, again, the basic blocks, right? If you don't have good circulation, if you don't have good diabetes control, if you have pressure and bad shoes and deformities of your feet that are not accommodated, that's going to lead to the amputation. So if your blood sugars are always high, that doesn't help. If your circulation is not good enough, that's not going to help either. And then again, the shoes is a big issue as well. So we try to address multiple factors, and that's what leads to the amputation. If you have had treatment and you've done your best, and the doctor has done their part, and still things are not working out, obviously we look for another way to help you and treat you. There's always other options. Ultimately, if there's cases where the amputation, unfortunately, is it cannot be avoided. I show up to the ERs here in town, and I go to multiple hospitals here in town, and I meet the patients for the first time, and it's sad for me because obviously I never had a chance to see these patients before the amputation happened. So I always I had to do that speech where I tell them, look, as much as I want to, I cannot save part of your foot, but I will do my best to save what I can. And then obviously we do the work we have to do to save what we can to make the patient be able to use their leg again. So that's a good question. Any other questions?
There is a question, is there a treatment for nerve damage?
Yeah, there's multiple treatments. Obviously, I always tell my patients, look, always let's find the cause of the problem. Let's just not treat, the problem. Yeah, well, you can treat the problem. You can give pills and medications and things like that. But there's a cause. There's an underlying cause of why people have this problem. So it can be one, uncontrolled diabetes. If you have diabetes, right? So if your blood sugars are always above, say like 150, or your hemoglobin A1C is above 7 or 7.5, you're gonna have some level of nerve damage and neuropathy, numbness, tingling, burning sensation on your feet. As far as treatments, people get gabapentin and get other treatments. There's obviously neuropathy from other causes, back issues, alcoholism, even the circulation. And Dr. Kumar, again, we work as a team, and he'll be talking probably about that too, that poor circulation can cause nerve damage. So, if we address the underlying cause of the problem, the numbness and the tingling and the burning sensation should get better with time. But again, I want to make sure that I'm honest again. And that's what patients like about me, is that, our bodies, go through stages in life, and unfortunately, our bodies don't get better with time. So, there's always going to be some level of nerve damage, but there's always treatment for that. And, that's why we're here. We want to treat the underlying causes to prevent further damage, but also to make the patients feel better. Any other patients or questions?
Yeah, well, one more question.
Yep.
This is from Mr. McCracken. Thank you for your question, by the way, sir. Or ma'am. Would too much sugar in your system cause the bottom of the arch around the side of your foot to turn black?
Yeah, well, yeah, again, if we go to the underlying causes of nerve damage, tissue damage, diabetes. So basically, yeah, uncontrolled diabetes will cause damage to the blood vessels over time as well. And that can cause, again, tissue damage to the bottom of your foot. I have a lot of patients that come to the clinic with, darkening and discoloration and brown hyperpigmentation, we call it, on the skin, on the legs and the feet. And they usually say, Dr. Nieto, what's going on? Like my foot healed up and it's really nice, but, I have these changes on my skin. That's what we call diabetic dermopathy. And that basically is caused by again, uncontrolled diabetes and poor circulation. And unfortunately, that can be permanent damage to the skin. But again, as long as you don't have a wound or an infection or something that will cause you an amputation, thankfully, that's not something to worry about, that hyperpigmentation. If it's truly changes of what we call ischemia is the lack of oxygen in the tissues on your foot, and it's black, and this color and purple, and it hurts, and it's breaking down, and your skin is breaking down, and it's creating openings or wounds. That's a medical emergency, in my opinion, again, because you can lose your leg, or you can have an infection, and it can cause you to end up in the hospital. So if you do have that at this time, sir, I will suggest, you can come over and see us at the clinic. Again, we're open, we're walking, and we're a walking clinic. We have multiple doctors in the clinic from 8 a.m. to 6 p.m. And you're welcome to call us too if you have any questions over the phone, and we'll try to answer the questions the best we can. And also, if you want to just maybe give me a number again over the message, and then we can do even a telemedicine over the phone to talk about this, okay? All right, with that said, I have to let Dr. Kumar do his presentations. I appreciate the time. Thank you again, and stay safe. Thank you.
Gentlemen, that was wonderful.
Thank you so much.
Amazing presentation. Thank you for your time, and really appreciate everything.
Yes, sir.
Hello, everybody. Let's see, that was great. Dr. Nieto touched on some of the issues of the foot and the preventing amputations. I'm going to talk a little bit about the what leads to amputations eventually, and how can that be prevented. Okay, so there's two categories of patients. One who already have the wounds into the lower extremities or foot. You see all these different kinds of ulcers and gangrenous changes, what we call them. You see how these are sores at various levels in the foot, big toe, dorsum, on the plantar aspect, heels, I just want to give you a summary of all these patients. They have severe peripheral artery disease, okay? And the problem with the peripheral artery disease and the wound is 80% of these patients will die within 5 years. That's a very high mortality. They're very sick patients eventually if not treated in time. And so that's very important. Not only these sores, when they develop now, the moment the sores develop, this patient is categorized into critical limb ischemia. Okay, that mortality or dying rate of these patients is very high. But how about the day before that the wound happened? Are they not at high risk on those during those times? Yes, they have the underlying basic problem, especially patients with diabetes, and that's what I'm going to focus on a little bit. That how can we prevent reaching this level and prevent amputations in these patients? Okay. So what happens is patients with diabetes, they have underlying neuropathy, and Dr. Nieto touched upon the neuropathy, the nerves that gets damaged, because if something doesn't get blood or oxygen or nutrients, those tissues in our body, whether it's brain, heart, or lungs, or kidneys, or nerves, they start dying and they don't function as well. And that's what happens with diabetes, neuropathy. This is a ischemic neuropathy most of the time. And these nerves, because of the lack of the circulation and lack of the oxygen, people stop feeling the foot, or they have maybe numbness or burning feeling, or they are not able to have that balance when they walk. They feel off, not feel comfortable. They feel their fear of falling, and they sometimes have to use cane. So this gait changes. They have to get up from the bed to go to the bathroom. They are afraid. They have to get hold of the wall, So a lot of these symptoms in patients with diabetes, and as Dr. Niero mentioned, I'm going to touch a few slides on those. These nerves are at least partially reversible because if you can find the underlying problem causing this, just like Dr. Niero mentioned, the blood sugar, if it is well controlled, that can help. If you avoid infections in the foot area, if you reduce the swelling, if you improve the circulation. So all depends upon what's causing that. Multiple areas are there to evaluate and treat these nerves. But what happens is once there's a nerve damage, then people don't feel their feet, and sometimes they'll bang the feet against the wall, or they'll put the foot in the wrong place, or like getting in the bathtub, in the bathroom, they hit the edge of the tub, and that's where the wound starts. Or nail cutting, these various ways these wound starts and these ulcers. Once there's an ulcer, we define these patients as critical limb ischemia, and there, because of the lack of the underlying blood circulation, poor circulation, and the blockage in the small arteries in the foot, these ulcers, they not only not heal, and on top of if they catch infection, then it's really bad. And that's what the stairway to amputation is. And we have to really reverse this cycle and, of course, prevent the diabetes. But once diabetes happens, you have to prevent the neuropathy. And if it happens, you have to treat these. So how do we achieve all that goal is, I'm going to just show you a quick summary how we've been missing to treat these distal vascular blockage and the poor circulation. This 71-year-old gentleman came with foot pain. If you see, there's some discoloration in the foot. A few days later, this big toe gets cyanotic. The doctor looks at it, and that yes, there is a poor circulation. The next step here should be evaluate their circulation with an ultrasound, and then restore the circulation, and this big toe can be saved. But instead, what was done was this patient had amputation of the big toe. That did not heal, and another week later, this area got gangrenous and black. And then eventually they ended up having the transmetatarsal amputation. The whole front foot was taken off. But you see, still the ultrasound to evaluate the vascular system has not been done, because you can already see that this area is going to be necrotic soon because there is no blood in this area. And then this is what happened. This area, and then they amputated that again. And then after another 2 weeks post-amputation, if you look at, they had to do another amputation. If you see, this area is not getting blood, and this next amputation is going to be the higher up, and then higher up. And that's what happened on this patient. This patient, after the below knee amputation, patient condition deteriorated, died within 3 months of this discoloration of the toes. What I'm trying to say on that is, most of these amputations in the legs are due to the vascular disease, the blockage or the poor circulation. And that's where we are missing the boat. If these patients are coming for the wounds or neuropathy symptoms or symptoms of the pain or rest pain or discomfort at night, not able to sleep, burning, cramping, we need to address the circulation. But what is happening? Look at this. In a 2001 study, only 49% of those receiving amputations had any diagnostic ultrasound. Okay. Has this situation changed in the last, since then? How about 10 years later in 2012? No changes. 20,000 Medicare patients data. Okay. No significant changes. There is a study done in 2018. Has that changed much? Well, some, but still there's a significant improvement that is needed. We just don't stop at the ultrasound. We need to make sure we don't end up having amputation as the first procedure. Look at Ali et al. Found amputation is the first procedure in 67% of Medicare patients who underwent major amputation. That should not be the first procedure. First procedure should be the restoring the circulation and optimize the level of the blood flow. Okay, that's very critical. This is, I'm going to just show you a few slides. What has changed over the last 5 to 10 years? Presence of the vascular disease has changed. In the past, we used to see, this is the blockage in the artery, in the superficial femoral artery in the thigh level. mid-thigh, okay? Now, if you see the disease, this is the foot level, see out of 3 arteries, there's only 1 artery visible, and that too very little blood flow here. So what we used to think before is the disease in the hip or the thigh area. Now we are looking at the ankle and the foot area. That's where the blockage is in these patients, especially with diabetes and the distal disease. And so what causes smoking leads to blockage in the higher up arteries, but and that's what we call the inflow disease. But how about outflow? Diabetes causes not inflow disease to that degree as the outflow. So outflow is the problem in patients with diabetes, and that's where you start seeing they are walking fine because there's not much blockage higher up. But at rest, when they're sleeping and they are resting, they have cramps, they have numbness, they have achy, heavy, burning feeling. So those are the distal diseases into the foot. They feel cold foot, Some patients tell me my foot is always cold. At night they have to put blankets after blankets, So that's very critical to understand that if patients have diabetes, they may not feel that much pain. They have neuropathy symptoms. They have the vascular symptoms, cramps, achy, heavy, as I'm telling again and again. These patients have outflow disease, and these are the patients at risk for amputations, because if these patients develop an ulcer, that's not going to heal. And that's what leads to amputation eventually. So this is critical to understand that before we develop that ulcer or wound, we need to identify these patients and evaluate them. That can be easily evaluated. So these patients have rest discomfort of some sort, or numbness, or achy, heavy, burning feeling of tightness. Some patients tell me they feel tight in their toes or the feet. They feel heaviness, So that's very important to understand. These patients with diabetes and outflow disease are like acute coronary syndrome, where we deal with the heart arteries blockage. These patients with higher up disease, they have angina, they walk, they have pain, they rest, and the pain goes away. That's not as critical as these patients with outflow disease and diabetes. How does diabetes affect the feet? Leg and feet cramps, numbness in the legs, feet and toes, a decreased skin temperature, they feel cold, they have sores, wounds that don't heal, they have plaque, calcium buildup, and it's like cancer of the arteries, basically. We do the ultrasounds, and we have some other things that can be done on these patients. I'm going to actually skip this interview. This patient here. This is the arteries of the gentleman. All 3 arteries are blocked in the below the knee area. Look at, there's not much blood flow to the foot. All 3 arteries to the foot are severely diseased. What we ended up doing is we put a small wire through a catheter into these arteries into the foot, and then get the wire across into the other arteries. So it is what we call is the pedal arch. This balloon is now going up through the arteries and the blockage. This is easier to get from feet up rather than the knee down on these arteries. And these arteries were eventually able to be opened by step through these balloons. Once we did that, then we have the long, let's see, how can I get this? And eventually, if you see this long balloon is used then after the short balloon, and we have the both these arteries open. This is the artery that was blocked in the thigh area. So now there's, look at the blood flow, beautiful, fast blood flow going. This is the knee area, and these 2 arteries were totally blocked before. Now you can see both these arteries have blood flowing very nicely, and level of blood circulation. And this is what we call is the pedal loop reconstruction. So pedal loop reconstruction is the way to go to have these arteries open into the foot, and that makes a lot of difference. What causes these small vessels involved? Patients with diabetes, especially with other risk factors like high cholesterol, hypertension, that leads to some of this plaque buildup. I'm going to actually show you other symptoms on these patients. They have achy, heavy feeling, cramping. They start walking slow. That's one of the very common symptoms, that they are, they don't do as much. They don't like to do as much because they don't feel good. They may not be able to say that they have the discomfort or pain, but they feel weak in the legs and feet. And now they don't go to malls anymore, or they are doing less. They go to mailbox, and now they have stopped taking interest in even picking up the mails or going. So these are the walking and the gait disorders, and a very common cause of this is the circulation disorders. They have the pain and paresthesia in the foot and the toes, as I mentioned, or the ulcer or gangrene eventually. I'm going to just get another thing that some of these patients will tell us, that they have hair loss on the feet or legs, and they have poor nail growth. Their nails are dry, scaly, and skin becomes atrophic. They have dependent rubor or color change in the legs and feet. So I'm going to actually skip some of the slides and show you what we are dealing with these in these arteries. You see how this is the foot arteries. There are 3 of them. This is the front artery, this is the back arteries, and there's a branch of that eventually completes the loop into the foot. And different colors tells where the circulation is. If the wound is here, and even if you open this artery on the front, it may not help this wound that much as it will be if you open this artery directly into this wound area. Look at this second toe here. If you look at on this gentleman, there's a ulcer here, the arteries into the foot, which we call it the digital arteries. If you see that there's not much blood going to this second toe here. And so we were able to open this artery with the balloon and then get into the second artery here. And you see how the artery is open with the balloon, and now the artery is supplying this blood directly to this toe, and this wound would heal. Otherwise, what happens is you end up doing amputation into these arteries, and that's a no. Amputation doesn't matter what level we do. Eventually, if we don't restore the blood circulation, we have to do higher and higher amputation. That's a very typical story we hear all the time. Another gentleman in the front, this wound is in the front. We know that this is the front artery, is the anterior tibial artery. And if you see this angiogram, you won't pick it up unless you really look at the foot carefully. See, this artery going to the foot is totally blocked right here. There's a branch here, but this artery is 100% blocked, dorsalis pedis. And so what we did was the angioplasty of this artery was done right here. And this artery now supplying the blood directly to the foot, and eventually got the pedal loop completed. There's some narrowing higher up. So eventually, if you see this, there was not much blood into the foot. And finally, we are able to get the blood and fully restored circulation right here. Okay. So this patient healed and very nicely. Another gentleman with rest pain into the left foot. Now this is a patient who had popliteal artery blockage, totally blocked artery right here, nothing going through. Actually, his CT angiogram was done and was found to have no flow. Was told that he's going to need amputation because there is no blood going below the knee. But I must alert everybody that if you are told that you have no blood and if there's a foot, so the blood is reaching somehow. It may be small collaterals, and that's where it's very important not to just believe the CT angiograms report that there's no blood. And that's why we actually not do CT angiograms that often. We rather depend and be able to see these small arteries with the ultrasound. And so this gentleman, we saw the, rather than going for amputation, we were able to get this artery restored and look at how the blood flow is restored into this beautiful popliteal and the anterotibal arteries, and patient healed, did not require amputation. I'm going to actually stop here. If there's any questions, please ask. But in summary, what I like to say, that patient who have ulcers or wounds, they are already at high risk for amputation. But even before you develop an ulcer or wound, and if you have symptoms of neuropathy, that could be because of the poor circulation, and the treatment of these poor circulation should start well before you start developing these wounds, so that amputations can be prevented in the future. Thank you very much.
Thank you, doctor. We have a couple questions.
Go ahead.
First question is, if I am controlling my diabetes with diet, do I still have to be concerned about circulation or nerve damage?
Yes, absolutely. Actually, what happens is majority of these patients, if the diabetes lasts for 12 years or more, doesn't matter what treatment you are taking, then the nerves get significantly involved, and you start getting these peripheral arteries, these small arteries I was talking about involved, and they have significant buildup, and poor circulation is there in many if not most of these patients.
All right. Next question. Is dry, cracked skin on the feet a concern if someone has a history of diabetes?
Yes, it is a significant concern. Actually, skin changes, the changes in the hair, the changes in the nails, they are real, and their circulation should be checked, because that could be those skin is not healing, or hair is loss is going on, or nails are not nice. It's partly at least in diabetic patients is because of the lack of the good oxygen, good nutrients, good circulation. So if you have poor skin, yes, please get your circulation checked.
All right. The next question, does high blood pressure, does high blood sugar cause nerve damage in the foot?
Absolutely, yes. And that's where these sugar or diabetes is what high sugar. And if there is actually high sugar, that must be controlled to reduce the progression of neuropathy in these patients. Yes.
And what exactly is the sugar doing?
Oh, what
to
sugar is
cause
doing
problems?
is actually, what sugar does is it builds up the plaque inside the arteries, and smaller arteries, and very small, tiny arteries. And the arteries around the nerves, if they are also involved with diabetic changes in these arteries, then the nerves don't get that much oxygen or the blood supply. And it's like they get choked, these nerves, smaller nerves into the foot. Okay, and this is called neuropathy. Neuropathy means the damage to these nerves because of the lack of oxygen and lack of circulation.
All right. Those are all the questions. Thank you so much, everyone.
All right. Thank you. Thank you very much
Thank you,
for everybody
doctors.
for their time and for attending the, our goal is to have a amputation-free Kern County. Okay, that's very, very important. Please, if you see somebody who has either been told that they need amputation, we like to take a chance and prevent that. Actually, we have had many patients that we have done that for. And so if you have been told you need amputation, please contact us. We will do our best and hopefully take care of things so that amputations can be minimized or prevented. Second thing is patients who are these patients who get into amputation is diabetic patients, especially with symptoms of neuropathy or rest pain or cramps or discomfort, achy, cold foot. Those symptoms are early symptoms where something can be done before you end up having so much blockages that nothing can be done once you have an ulcer wound. So those are the ways to prevent amputations. Thank you.
Great. Thank you, everyone, for your time. We appreciate it. Have a great day.
All right.